We will start with the next speaker. I invite Dr. Prashad Narayan sir, senior consultant medical oncology and director of medical oncology, Site Care Cancer Hospital, Bangalore. He'll be speaking about neoadjuvant chemotherapy alone versus, neoadjuvant durvalumab with or without stereotactic body radiotherapy. Prasad sir, hai kya rakha?
Third. Good morning. At the outset, I would like to thank the organizers for this
Sir, you
opportunity.
are.
The next 7 minutes or so, I will be discussing about this study, which is a phase 2 randomized trial, which looked at neoadjuvant durvalumab alone or along with the stereotactic body radiotherapy in patients with early stage non-small cell lung cancer. So we know that there have been attempts at neoadjuvant systemic therapy, be it chemotherapy or immunotherapy recently in early stage lung cancer. But adding SBRT as an immunomodulator hasn't been tested in this context. And that is the basis of this study, which looked at pathological CR as the primary endpoint. And the PAT CR rates usually with any sort of neoadjuvant therapy has been into the tune of 15 to 45% in different studies. So it's a randomized phase 2 single center study. One arm had 2 cycles of durvalumab, the other arm had durvalumab plus SBRT 8 gray, 3 fractions. Primary endpoint, major pathological response, which is defined as less than 10% viable tumor cells. 96 patients screened, 60 enrolled, 30 in each arm. And from this 30, 26 in each arm underwent surgery. And the post-operative treatment was radiation or chemoradiation as per the standard guidelines. What happened to those non-surgical patients, which is our main concern when we treat an early stage cancer with a neoadjuvant therapy? The single agent arm, 4 patients who did not undergo surgical resection, 3 were not explored because one refused, one had a stroke, one had bone metastasis. And the one who was explored had pleural metastasis, which is a common thing in lung cancer. When we stage a patient as early stage and we go in, we might find metastasis. In the combination arm, one patient who was not explored had a cardiopulmonary event. Three of them were explored for surgery. One had lung mets, one had pleural met, and one had aortic invasion, which made it inoperable. Then from the demographics, what were the key points in these 2 studies? My first look was how many patients would have had a stage 3 disease. So almost half, 47 or 40% in both the arms had stage 3 disease. And invasive mediastinal staging. This study had a mandatory PET-CT and invasive mediastinal staging in those who were indicated. It was done in 40% and 43% respectively. Adenocarcinoma was more than squamous cell carcinoma. The key thing I would say, which might have influenced the result or not, we can't say, because both sides got the durvalumab, was the PDL1 expression. The PDL1 expression percentage more than 1 was 77% in the combination arm, which can explain the differential results actually. We can't say with a small study. EGFR mutant patients were almost 20% in both the arms. So major pathological response occurred in 2 patients, that is 6.7% in the monotherapy arm versus 16 patients, which is 53.3% in the combination arm. Among these 16 who had a PAT CR, who had a major response, 8, that is 50% of them had a pathological CR, which is significant. So the study met its primary endpoint straight away. P-value is highly significant. And there is no need to even put a statistical calculation to find out this difference. What were the adverse events? The second cycle of durvalumab was withheld in 3 patients of the combination arm. Grade 3 or 4 adverse events occurred in 17% of the patients with monotherapy and 20% in the combination. Serious adverse event, 2 in each group. One of pulmonary embolism and stroke in monotherapy. We discussed that in the patients who did not undergo surgery. And 2 SAEs of one of pancreatitis and fatigue in the combination arm. So a typical immunotherapy study, which with the AEs being described are very similar to that. So as a discussion, the trial met the primary endpoint, which was whether adding SBRT will improve on outcomes from durvalumab alone. And as I discussed in the demographics, There were differences in the PD-L1 positivity among patients in both the arms. Now, since this study had durvalumab in both the arms, PD-L1 was more in the combination arm. We don't know whether the effect of SBRT, just giving SBRT 8 gray into 3, was the impact in improved PAT-CR, or was there any effect of a immunotherapy radiation, and that cannot be done in this study, in such a small study. But definitely this rakes up this question of adding SBRT as a convenient mode of radiation along with 2 cycles of immunotherapy. The pathological response in the control arm was less than that is reported in other trials. One possible explanation could be the lesser number of patients with PD-L1 positivity, or there could be any other reason for that. So my take from the study, is it a study worth discussing? Yes, it is a study worth discussing, because the SBRT 8 grade to 3 is easily possible as a neoadjuvant arm. In this study, the patients were taken for surgery. The median time to surgery was 4 to 5 weeks, which is significantly less than most of the other neoadjuvant studies. So in that way, it is a simple study to be, and the period was not very high of the patients being diagnosed and waiting for the curative indent resection. And if 54% of them will get a major pathological response, it's worth doing something before surgery. And so definitely the study opens up a question of trying this in a larger study. And most of the studies which are looking at combination of chemotherapy plus immunotherapy combinations, there are phase 3 trials which are looking at this question in this era. So looking at a combination as a potentially curative indent therapy is something possible. I'm sure the surgical colleagues will now jump up on me, whether we can just give immunotherapy and radiation as a combination and cure more patients of early stage non-small cell lung cancer, be it adenocarcinoma or squamous cell carcinoma. So the study definitely met its primary endpoint, worth discussing and worth taking to a different level in a different design. That's my take from this study. Thanks a lot for the opportunity.